So today's topic is about provisional restorations in FPD. So coming to the introduction, the provisional restoration is also called as the temporary restorations or interim restorations and transitional restorations. So we can define the provisional restoration as the restoration which is fabricated for a particular period of time until definitive restoration is fabricated. So usually we make the provisional restoration after the tooth preparation and preferably in the same appointment. And next, what are the ideal requirements of provisional restorations? So we can classify the requirements of provisional restorations into biological requirements, mechanical requirements, and aesthetic requirements. So coming to the biological requirements, it includes the pulp protection, periodontal health, positional stability, and prevention of fracture. So coming to the first factor, that is the pulp protection, means the provisional restoration we are giving should protect the prepared tooth by preventing the sensitivity and irritation to the pulp. And next factor is the periodontal health. That means the provisional restoration should have a good marginal fit, and the surface of the provisional restoration should be smooth, so that there should not be plaque accumulation, and also it should facilitate the easy plaque removal and maintain the periodontal health. So next factor is the positional stability. That means it should maintain, the provisional restoration should maintain the interarch and intra-arch stability, thereby preventing the tooth migration, supra-eruption, and neuromuscular imbalance. Next is the prevention of the fracture. That means it should protect the prepared tooth from fracture. This is most common in the case of a partial coverage restorations, when the margin of the preparation is close to the occlusal surface of the tooth and it could be damaged during chewing. So coming to the mechanical requirements, that is is divided into three, that is functional, loss of retention, and removal for reuse. So functional means it should be functional. The provisional restoration should be functional, that so that during the mastication it should not fracture, so that it should possess the good compressive and flexural strength. So when the strength of the material which is used for making the provisional restoration should always be lower than that of the definitive restoration material, but the cross-sectional size of the connector should be larger than that of final restoration to reduce the potential failure which is produced by the stress. And the next factor is the loss of retention. That means it should have a close adaptation to the prepared tooth surface, so that there should not be dislodgement. We can increase the patient visit. Then coming to the next factor, that is the removal for reuse. That is, whenever needed, we have to remove the temporary restoration and re-cement the temporary restorations whenever required. So always make sure that the provisional restoration should be fabricated with adequate thickness, and it should be cement. It should be always cemented with a weak cement. And while removing, also it should not break. So we should give adequate thickness for the provisional restoration. So coming to the aesthetic consideration, which is of important concern when we give an anterior FPD, that means it should match the shape, size, color, and texture of the restored tooth, especially in the anterior region. And color stability is also important if you are planning to give the provisional restoration for a prolonged period. So these are the requirements for the provisional restorations. So next, how can we classify the provisional restorations? So provisional restoration is classified according to the method of fabrication, according to the material used, and according to the duration of use, and according to the technique of fabrication. So according to the method of fabrication, it is divided into preformed and as well as custom made. So preformed means it is already prefabricated. The anatomic form is already prefabricated and it is available in different size and types. So we have to select the appropriate size, measuring the mesiodistal and occlusal cervical height of the teeth, and we can modify the preformed anatomical form, and tissue surface is usually relined to fit to the prepared tooth. So preformed is indicated in the case of a single tooth restoration. What are the advantages with a preformed type of provisional restoration? Means it is less technique sensitive to fabricate and it requires less chairside time. Disadvantage means it cannot be used for FPD, and most of the times modifications that are needed to fit to the prepared tooth. So next type is that custom made, that means anatomic form and shape of the tooth being restored is fabricated by the dentist or the dental technician. So advantage with this technique is that the provisional restoration is having more adaptation to the tooth. That means because it will have an intimate contact between the provisional restorations and the prepared tooth. So this type is most commonly used for the fixed partial dentures. So advantages means it can be used for any clinical situation and it is having a better fit. The only disadvantage means it requires more time than that of the, because we need to take an additional impression and we need to fabricate directly or indirectly using that additional we have to fabricate that using direct or indirect method. So that is how we make a custom made temporary restoration. So according to the material used, we can classify the provisional restoration into two, that is made up of resins and made up of metals. So resins, it is again classified into preformed and custom made. In preformed, we can polycarbonate is there and cellulose acetate is there. In custom made, acrylic and bisacril composite is there. And coming to the metals, that is the preformed is aluminum, tin, silver, nickel, chromium. Custom made means cast metal alloys. According to the duration of use, also we can classify as a short-term temporary restoration and a long-term temporary restoration. So short-term temporary restorations means its use is limited to up to 2 weeks, and we usually use any cast metal is not used, and we usually use any preformed or custom-made materials. And this is routinely used as an interim restorations until final restoration is fabricated, such as for crowns and FPDs. Next is the long-term temporary restorations, means to be planned temporary for to be used for a few months, and usually it is made with a cast metal. And in the case of a full mouth rehabilitation, or in the case of a gross maxillomandibular discrepancies or the temporomandibular joint disorders, we have to give a long-term temporary restorations. And in the case of a maintenance of vertical dimensions while restoring this anterior teeth, and for healing after periodontal surgery, and if the orthodontic treatment is required prior to the fabrication of final restoration, in all these cases we have to give a long-term temporary restorations. Next classification is based on the technique of fabrication, that is direct technique, indirect technique, and direct indirect. So direct technique means restorations are fabricated intraorally. Indirect means it is fabricated extraorally on the cast. Direct indirect means it is fabricated by means of both the combination of intraoral as well as extraoral procedures. So what are the different ideal requirements for the provisional restorative materials? That means it should have adequate strength, wear resistance, biocompatibility. It should be dimensionally stable. It should be easy to polish and recontour, and it should be odorless and non-irritating. It should be chemically compatible with the looping cements and should be aesthetically acceptable. It should have adequate working and setting time and easy to repair. So what are the different custom-made materials which is used as provisional restorative materials? That is mainly resin and metals. In resin, we have got two types, that is acrylic and bisacril composites. That is polyneedle metacrylate, poly-R metacrylate. And in the case of bisacril composites, it is chemically activated, light activated, and dual activated. And in the case of metal, we have got the cast metal alloys. Next is the preformed crowns. That is according to the type of the material used for fabrication of the anatomic form. Crowns are classified into two types, that is resins and metals. In resins, it is polycarbonate and cellulose acetate. In metals, it is aluminum, tin, silver, and nickel chromium alloy. What are the recent advances in the provisional materials? That means we have got the computer-aided design and computer-aided engineering can be used for fabricating the precision milled acrylate, polymer filled conduit, simple and multiple unit provisional restorations. So it will be having an increased strength and fit along with a customizable solution. And the main disadvantage with this type of CAD designed material is that it is having an increased cost. So let us see the technique for fabrications in detail. So first is the direct technique, that means restoration is fabricated intraorally. So it is basically divided into two types, that is the preformed with the polycarbonate crowns and custom made with the index. And in indirect technique means we are fabricating extraorally on the cast, and it is also preformed with the nickel chromium crowns and custom made with the template. And direct indirect means it is fabricated using combination of intraoral as well as extraoral procedures. So let's see the direct technique in detail. Direct technique means restoration is fabricated intraorally, that is directly inside the patient's mouth. So let's see what are the advantages, because it has less time and less cost, as there is no need to make, we don't have to make a cast. Disadvantage means it can be used only for a simple unit restoration and a short span bridges. And we require the patient cooperation because the chairside time is more. And also, while fabricating this provisional restoration, the material can release the exothermic heat at the time of setting, and which can cause the pulpal irritation. And there is offensive odor, and it is difficult to remove the provisional restoration if we are not giving proper attention to the setting. So basically, it is of two types, that is a direct technique, that is a preformed, that is polycarbonate provisionals. So how to fabricate the preformed polycarbonate provisional? So it is better to understand this technique using a figure. From this figure, we can easily understand the steps. So preformed crowns are available like this. So in this, you can see different size, which is in which you can see preformed anatomical forms. So this is meant for the anteriors. So from this, appropriate size of the crown is selected from this assorted kits. So how to select is that we have to measure the mesial using a divider. We have to measure the mesial distal width of the tooth and as well as the occlusocervical height of the tooth. And from this, so after this, compare this with this kit. So in this size is best suited for this this measurement. And after that, we have to in this case, 1 is the best. So 1 is the best suited to this measurement. And if this is actually after selecting the crown, it is tried inside the patient's mouth. So from after trying, we understood that the incisal length is more. So when the incisal length is more, never reduce from the incisal aspect, because excess portion is to be reduced from the cervical aspect. So excess portion is marked on the cervical portion, and it is trimmed carefully at the cervical part, and never that is the importance we have to give, never trim the incisal portion. So the height has to be reduced from the cervical aspect, and then we have to excess portion is then marked on the cervical portion. So we have to apply the petroleum jelly then onto the repair tool, and the trimmed crown is then filled with autopolymerizing resin and for the purpose of relining, and is seated onto the repair tool. So thus make sure that while relining the tissue surface, make sure that it should be once the dough stage is reached, the crown should be removed by rocking facially, and it should be placed in the warm water. Then after that, the polymerized crown is trimmed, finished and polished and cemented with the provisional cement. So this is how the direct technique, that means we have to measure the mesiodistal as well as the occlusocervical height and compare that measurement from the compare that measurement and select an appropriate size from the assorted kit. Then we have to try inside the patient's mouth, and if it is excess inline, always trim from the cervical portion. And after that, the trimmed crown is filled with autopolymerizing resin and is seated onto the prepared tool. So once you once you find that dough stage is reached, slightly rock the crown facially and place in the warm water. After complete setting, polymerized crown is trimmed, finished and polished and cemented with the provisional cement. So that is the direct technique using preformed provisional materials. Next is the direct technique using custom-made provisional materials using index. In this case, anatomic form of the provisional restoration is to be obtained by making an impression prior to the tooth preparation and restoring or replacing the teeth to be temporized. That means how to plan for a simple unit restorations. That means if the tooth is damaged, first of all, we have to restore the tooth with wax, and index is made intraorally with a putty or irreversible hydrochloride impression material. In this case, you can see it is an we are going to make a custom made temporary for a fixed partial danger that is using the direct technique. In this case, patient is having an existing RPD. So we can ask the patient. So this is the pre-operative picture. So we are going to prepare this FPD, and this is the patient's intraoral picture. But the patient is already using an RPD. So because of that reason, we can even ask the patient to insert the RPD. So you can see already this space is filled with an artificial tooth. If the patient is not having an existing RPD, you have to make a cast, and then we have to do the artificial teeth arrangement. So that is so we cannot use a direct technique in this way. So we have to do an indirect technique. So in this case, as the patient is having an RPD, you can directly go for a direct technique. So if there is no existing danger, we have to keep a artificial teeth which is arranged or waxed up on the diagnostic cast, and index is made with a putty or a reversible hydrochloride of the tooth to be restored on the cast. So as the patient is having an existing RPD, we can directly go for the impression, because patient is already having an existing RPD. So for making an index, we are going to take an impression from this and we are going to pick up this RPD onto the impression. That is, this is how we are going to make an index. So after putty indexing with an existing RPD, all the flanges are trimmed. So already patient is having RPD inside. We have taken impression. So this RPD is picked up in this impression, and then we have to we have to trim the flanges from this RPD. So next is we have to do the patient has to be recalled, and we have to do the tooth preparation. After the tooth preparation, we have to apply the separating medium onto the prepared tooth. Then we can mix the provisional restorative material, and it is poured in the index. Then index is reseated inside the patient's mouth. So this is how, and it is allowed to set, this provisional restorative material is allowed to set completely in the index. After the completing the setting, it is then contoured, it is then removed from this index, and it is then contoured, polished, and it is cemented. So this provisional after removing from this impression, it looked like this. So the margins of the provisional restoration has to be trimmed properly, and then after trimming and finishing and polishing, you can cement the provisional prosthesis using a temporary cement. So this is how you make a direct provisional restorations by direct technique using custom-made material. So that is, the patient is already having an existing RPD. So we have to make an index. That means by taking an by picking up that RPD into an impression, we have to trim the flanges from the impression. We have to prepare the tooth. Then after preparation, we have to pour the resin to this index, and as the index is reseated into the mouth. Then finally, after completing the setting, the provisional restoration is removed from the index, and excess is trimmed like this. And finally, after proper trimming and polishing, it can be cemented using a provisional restoration, a provisional cement. That means temporary cement. Next is the indirect technique. So indirect technique means we are fabricating the provisional restoration extraorally on the cast. So this is always the preferred method for making the provisionals for FPD. And advantage with this technique means patient is not affected by any setting properties of the material, because we are doing the temporary, we are fabricating it on the extraorally on the cast. Disadvantage means it takes more time, and we need to sometimes take 2 impressions are made for tooth preparation, and also it will cost more cost. So that is indirect technique, that is the preformed. In that also it is preformed, and is there custom made is there. So indirect technique, that is the preformed using nickel chromium crowns. In this case, same procedure. That means we have to, there will be preformed crowns are available in the kit. And we have to select the appropriate size of the nickel chromium crown is selected. And then we have to trim the excess height is trimmed from the gingival margin. So first, after selecting the appropriate size, we can extend the cervical margin and we can actually push the crowns onto the cast. And then once it is properly adapted, if the excess height is there, it can be removed from the gingival margin. So excess height is removed from the gingival margin and the gingival margin is then smooth. And the axial surface is then contoured with the pliers. That is, axial contours has to be contoured with the pliers. And then after that, we have to check the occlusion. After that, again, we sit onto the cast and check the occlusion with the articulating paper. And also crown is filled with the provisional cement. So, and this crown is filled with provisional cement and it is then seated. So excess cement is removed from the crevice with an explorer. So this actually they have shown onto the cast and they have to cement the crown inside the patient's mouth. They ask to understand the steps they have shown on the cast, but they have to show it onto the. Actually, we have to cement inside the patient's mouth. Only fabrication part of this is still here only. So after this occlusion, occlusion is checked with the articulating paper, we have to recall the patient and this crown is then tried onto the patient's mouth after tooth preparation, and then it is to be filled with the provisional cement while cementing. So this is how, that means the fabrication part is completed extraordinarily on the cast. That is why we call it as an indirect technique. Next is the indirect technique, custom made provisionals using a vacuum formed template. That is, a diagnostic cast is obtained and artificial teeth are arranged, and putty is used to stabilize this artificial teeth on the cast instead of the wax. So this also we can easily understand from the figure itself. So this is the condition in which there is a patient is having missing anterior teeth. So diagnostic, we can see the diagnostic cast with missing mandibular anterior teeth. So we have to arrange the teeth onto the diagnostic cast, and then we have to keep this cast should be placed on this machine, and thermoformed sheets are heated and allowed to sag, because we are going to make a temp index which is using thermoformed sheets. So after a complete adaptation of the thermoform sheet, the cast will look like this. So this is the cast with artificial teeth and this is vacuum form. So we have to trim the excess areas of the thermoform sheet, and then we have to recall. Now this is the template which we are going to use for our temporary restoration. Next, we have to recall the patient and tooth preparation. We have to do the tooth preparation, and after that we have to take the impression, take the master impression. Then additionally we have to take one impression for the fabricating the temporary restoration. So this is the stone cast which is poured following the tooth preparation. So this template is placed on the cast to check the fit after tooth preparation. So we have to, so already we have fabricated a template, and then you have to check the template which is placed on the cast, and it is, the fit is checked. After that, you have to fill the template with the provisional material, and then you have to seat the template onto the cast, and this is how the template looks like after it is removed from the cast after polymerization. So in this, provisional restoration is trimmed and fitted on the cast, and this is the buccal view. So in this case, the fabrication part of the provisional restoration is always done on the cast. We are not using any patient's help, or we are not making this inside the patient's mouth. That is why we call it as a indirect technique. After that, we have to recall the patient, and if the fabrication is over on the same day, we can cement the final provisional restoration immediately after the tooth preparation. We can cement the final provisional FPD is cemented in the mouth using a temporary cement. So this is how a direct custom-made method is done, custom-made provisional method this is the custom-made method for making the provisional restoration, that is using vacuum formed templates. So this is how it looks like. First, we have to fabricate the templates on the diagnostic cast, and then after the tooth preparation is done, then using this again after tooth preparation, we are pouring the cast. We are not directly using the template inside the patient's mouth. We have to pour the cast after tooth preparation and check the pitch of the template onto the cast. Then we have to fill the provisional restorative material onto the template, and this template is removed from the cast after the polymerization. Excess area is to be trimmed, and final correction is all trimming correction and rechecking of the fitting on the cast. Everything is done extraorally on the cast. Only the cementation part we are doing on inside the patient's mouth using a temporary cement. So all the fabrication part is we are using extra. It is made extraordinarily on the cast, so we call it as an indirect technique. Next technique is the direct indirect technique. In that case, we are using the combination of the direct as well as indirect technique. That means we are making the provisional restoration on the cast. That is a direct indirect way. But final relining of the provisional restoration is done inside the patient's mouth. That means we are using a direct technique. So it is in this case we are using a combination of direct as well as indirect technique. So let's see the figure. First, the diagnostic impression is made before the tooth preparation and cast is to be applied. So this is our intraoral picture. So we have to make the temporary for this restoration. So in this case, here we are planning a full mouth rehabilitation. That means in the we are planning to prepare all the teeth in the upper arch. So you have to make a temporary for all the teeth. So this is the intraoral picture. So after taking impression, we have poured the diagnostic cast, and all the missing areas are to be replaced with the artificial tooth. Any corrections are to be made, final corrections are to be made with the wax. Then after that, we have to make a putty index is made up of the restored cast. Putty index is fabricated. And next is we have to, so this completes the fabrication of the putty index. After that, we have to artificial teeth which is arranged is removed, and abutment teeth are to be prepared on the cast. So here we are arbitrarily preparing this abutment teeth. So make sure that the preparation should be minimal than it is intended for the final restoration. So if you are planning for a final restoration, then always make sure that you are doing only a minimal preparation on this cast than it is intended for the final restoration. So this is how you completed the preparation on the stone model. So we have already made the index. So that index is to be filled with the provisional material, and it is mixed and poured into this index. Then after that, you have to keep this index, which is filled with the provisional restorative material, onto the prepared stone cast, and we have to secure it using a rubber band. So this is the prepared stone cast, and we have to secure onto the cast using rubber bands. So this is how the provisional restoration looks like after removing, and it is already trimmed and fitting was already checked on the cast. So this is how it looks like. And so after removing this index, we have to trim the provisional restoration materials, and indirect provisional restoration is trimmed and fitted onto the cast. So we can, next we are going, so first the fabrication part, that is indirect technique. Indirect technique is used for fabricating the provisional restoration. Then that means this provisional restoration is fabricated indirectly on the cast with a tentative tooth preparation that will not fit accurately after the final tooth preparation. And this restoration is fabricated and kept ready before abutment teeth is prepared. So when so now temporary is always ready. Then we have to recall the patient, and all the abutment teeth are prepared inside the patient's mouth to its final shape. Then after the preparation, for making the provisionals, we have to reline the already fabricated temporary. And so we have to fill the provisional material material to be relined should be filled inside this provisional restoration, which is already fabricated. So after the tooth preparation in the patient's mouth, acrylic resin is added to the retainers in the indirect provisionals. And this is then placed in the mouth after application of the separating medium and adjacent areas, and held with the finger pressure till the initial set. So only after doing a relining procedure, this temporary will fix inside the patient's mouth. And it is removed before the final set and exothermic reaction begins and allowed to polymerize in the warm water. And this is the direct method performed intraorally to obtain the accurate fit. So the restoration is trimmed, checked for the fit, and occlusal correction is done, polished, and cemented. So this is how the temporary is cemented after finishing and polishing. So this is the so why it is called as a direct indirect technique, because we are already using the stone cast for the fabrication of temporary. Only thing what we do in the cast is that we are doing a preparation which is less than that intended for the final preparation. Then we are recalling the patient, and final bits of the provisional restoration we are correcting inside the patient's mouth. So that is direct technique. So we are using a combination of direct as well as indirect technique. That is why we call it as a direct indirect technique. So this type of technique is mainly used when you plan for a preparation of a multiple abutments in a patient. So if you are planning for a full mouth rehabilitation, so we have to prepare all the tooth. So in such cases, you can use this technique as a method for fabricating the provisional restorations. So coming to the limitations of the provisional restorations, it is having a lack of adequate strength, which when compared to that of a final or definitive material, it should have a strength, it should be less. So if we do not fabricate inadequate thickness, it can lead to the fracture of the provisional restoration in the case of a long span FPD, and also in the case of patient with bruxism and reduced interocclusal clearance, and also inadequate marginal adaptation compared to that of the definitive restoration, poor aesthetics in the case of a long-term provisional restorations, and plaque accumulation. If we don't finish the surface properly, we can lead to plaque accumulation, and mild to moderate tissue irritation and a compromised bonding characteristics. So coming to the cementation, ideal property, the cement used to seal the cement used for cementing the provisional restoration should have the ability to seal against the leakage of the oral fluid, and also it should have adequate strength, but we have to remove whenever required, whenever intended. And low solubility, it should have an obtudent effect because it should provide a pulse protection, and it should be easy of eliminating the excess. And main thing is it should have an adequate working and a short setting time. So commonly used temporary cement is a zinc oxide eugenol, reinforced zinc oxide eugenol, and also non-eugenol cements. Then, main purpose of the cement for looting the temporary restoration is that it should have adequate strength, but whenever required, we have to remove and re-cement it. So that is it should have only an strength which is to be for which the temporary is to be retained for that intended time. Only definitive cement should have the strength that it should not, we don't have to remove the definitive restoration of it. So that is coming to the removal of the provisional restoration. It can be removed using forces which is given parallel to the long axis of the tooth preparation. So we can remove the temporary restoration using a hemostatic artery forceps, which is mainly used for a single unit restoration. And also you can loop the dental flows under the connector at each end of the connector. Is useful in the case of an FPD. Either you can remove using a hemostatic artery, and also there are different different types of crown removers are also used for removing the provisional restorations. But mostly it will be it's okay with the dental flows, and hemostatic artery forceps will work for the removal of the provisional restorations. So coming to the conclusion, provisional restoration is a temporary restoration which is mainly used to prevent the tooth from injury, abnormal tooth movement, and it should fulfill the ideal requirements and should be well tolerated and easily accepted by the patient. So main aim of provisional restoration is we have to mainly protect the abutment tooth till we give a definitive restoration. So that is the main aim of the provisional restoration. So while doing the provisional restorations, we have to make sure that the material should have a less strength compared to that of the definitive restoration, but also make sure that the connector size should be more, that it should not fracture the provisional restoration till we give the definitive FPD, definitive restoration. So it should maintain the inter and as well as intra arch stability of the arch also. So this is a very important question for university exam, and normally we call it as a temporization. Temporization is the terminology which commonly used for cementation or the fabrication of the cementation of this provisional restoration. So if a question on temporization asks also, you have to write about the provisional restorations. So thank you.